I'll start with number 1.
Frances Cranfield from Beds and Hearts faculty. We have reached a manpower crisis now for a number of reasons, but the number of people leaving general practice is at crisis point. What 3 things do you think that the government could do to help entice professionals to remain in general practice in the UK, to stop the hemorrhage now of all the skills and knowledge which is being lost to our patients?
You take 3. Yeah.
We'll collect 3 at a time, so I'll go to number 2, please.
In Woodhouse, we have a term, old before your time. We look the focus on over 75s. A lot of our patients don't live to 75, and that's because of the combination of health inequality, health equity, long-term conditions like diabetes, substance misuse, alcohol dependency, you name it, COPD. What are you going to do about the crisis in community nursing for people with long-term conditions who are housebound? Community nursing has become task-centred. There's been a hemorrhaging of experienced nurses, and we no longer have them in the community. That's a major reason why we can't deliver the care, personalised care we need to give.
Thank you. Number 3, please, and then I'll come to number 4 when I've had the chance to respond. Number 3.
Okay, thank you for coming to speak to us today. My name is John Patterson. I'm the clinical champion representing the college's work in health inequalities, and my question is, how high on your agenda is addressing and reducing health inequalities? And especially in the context of assistant physicians, we believe the NHS should be best where it's needed most and not cheapest where it's needed most. Thank you.
Thank you. In fact, we will take 4, just do the round and then hopefully get another round in. Anyone at 4? Yes.
Yeah, Stephanie Giorgio, GP in Deal. Mr. Hunt, there's an elephant in the room, well known to all of us who actually work in general practice every day. This is the ever-increasing inappropriate demand from patients. Instead of addressing this, you and the press make it worse by continually denigrating general practice. And encouraging patients to be ever more demanding. We are exhausted, drowning, and quite frankly, furious with you. What are you going to do about it?
Thank you.
Well, I do believe that we have to respond to the changes in expectations of the public, and we can't totally run away from them. I mean, one of the reasons why we have huge pressure in A&E departments is because the public are saying that if something goes wrong on a Saturday morning, they don't want to wait till Monday or Tuesday to go and see their GP to sort it out. They want to get it sorted out right away. And if general practice is going to be at the heart of a modern NHS, then we have to respond to those changing expectations. What I would disagree with, I'm just taking these questions in reverse order, is any suggestion that that I am not fully behind GPs. I have, for the first thing I did, I came to your conference last year. I've always talked about a stronger role for general practice. I've always campaigned for more resources to go into out-of-hospital care. And I've tried to make a start at some of the changes to the contract that have made it more difficult, but I've concluded that in the end, there is a very big capacity problem. So what you talked about in terms of burnout is something that worries me a lot. And I've travelled with Maureen to countries that have successfully addressed the issue of GP burnout. And I think there is a way forward. And going on to some of the other comments you made, because the first question from Francis was about what can we do to address workforce pressures now? We have about 1,000 more full-time equivalent GPs in the system. I think one of the things that we need to do is to talk, but I also think different workforce models that can reduce pressure on general practice, can reduce some of the admin tasks that you have to do as part of your responsibilities, because we can't just wait until we have another 5,000 new GPs coming into the workforce by the end of the next Parliament. We actually have to deal with those pressures today. And a very important question about district nursing and community nursing. I think it's wrong that we have seen a decline in the number of community nurses, although there's an issue about how you count it. But I've addressed this problem in hospital nursing. I've been very clear that I don't want poor care in hospitals, and I want to do the same in community nursing. And I think the way you do it is actually by having better metrics that actually tell you whether in the community we are giving the care we should be to vulnerable older people. And at the moment, one of the problems we have is that we don't have the metrics that expose where those gaps are. Health inequalities, and that in terms of how we do that, was actually something I was having a discussion with RCGP leaders last night, and we all agreed that one of the crucial changes that we need to make is to establish proper measurement of quality of care in the community, so that where it is not what we want it to be, something gets done. And finally, in terms of health inequalities, I completely agree with you. That is what the NHS is for. The NHS is about making sure everyone, no matter who you are, gets the highest standard of care. And I think one of the things that we will get from this workforce study that I've asked Health Education England to do is knowledge precisely area by area as to where the gaps in provision are. And I think that will shine a spotlight on under-doctored areas, in deprived areas where there is a chronic shortage and has been for very many years of GPs. But I think it will also shine a spotlight in other areas that may appear to be more affluent but have a huge challenge because of an ageing population. Rural areas, for example, where there are huge pressures because of the distance you have to travel. And I think we need to know those too.
Thank you. Have you time for another round?
Yeah.
Okay, we'll continue. Great, short questions, fantastic. Number one, please.
Thank you. Mark Purvis, Yorkshire and Humber. I've got the data in front of me. You've claimed 1,000 more GPs. In 2010, there were 35,120 GPs in England, and in the last census, there were 35,561. Now, my maths isn't as good as yours, Jeremy, but that's nowhere near 1,000. During that time, the population has grown, and the number of GPs per 10,000 patients has actually fallen from 7 in 2009, 6.8 in 2010 to 6.6. You may not think that a drop of 0.2 or 0.3 GPs is significant, but in a practice size of 10,000, that's 3 surgeries a week lost. My colleagues are working under incredible strain. When are you going to be honest about the actual fall in GP numbers and not keep on presenting it as a rise?
Can I just... I'm sorry, I was going to listen to all the questions, but I think it's a strong thing to accuse people of dishonesty. So the figures that I presented were the full-time equivalent figures that have been provided to me by Health Education England. They tell me that in England there is a rise of 1,000 in the number of full-time equivalents. I don't think that's enough. That's what I was saying today, and I think I couldn't be more... Yes,
all right, Mark.
I don't think that's enough. I think we need more. And I think that's why what I've talked about today is how we increase capacity in general practice.
Okay, thank you. Number two.
Stephen Lawrence, Clinical Diabetes Lead, RCGP. Thank you for being very brave to come along and speak with us today. But I feel that perception is a very important aspect, and particularly for youngsters coming into the profession. I'm fortunate to have a daughter who's actually a medical student here in this city. And the concern that was actually raised during a recent discussion was really, where can I go into medicine? Because there is vilification of the profession everywhere I see. Now, I'm here standing and trying to explain to her, well, it's a good thing to do, it's a good thing to go into, but it's difficult to justify the recent news story stating that GPs' incomes are now supposed to be published from 2016 onwards. In regards to promoting transparency within the NHS, could you explain what the benefit of this transparency is?
Thank you. Number three, please.
My name's Dr. Simon Abrams. I'm a GP here in Everton in Liverpool. Continuity of care is part of the foundation of what is the great strength of British general practice. But every contract change that's happened over the last 10 years has, inadvertently sometimes, damaged it severely. Aside from talking about it, what are you going to do about that?
Thank you. Number 4.
Hi, I'm Dr. Ross Stewart. I'm representing the GPs in training and the first 5 on behalf of the future of the college. Welcome to conference. My question is this. In interest of transparency, your recent announcement, which I personally applaud, to extend healthcare 24/7, I think that's a great modern idea. But could you explain to us just exactly the process that you went through, and who did you involve in that process before announcing this? Because to a lot of the trainees, it came as a surprise. And we were just interested in who the GPs that were involved and where are they, and what feedback did you get from them before announcing this?
Thank you. Will that be all the questions? Thank you. Jeremy will respond to those ones, and I'm very sorry, I'm afraid we will not have time for any more. So I do apologise to those of you who've patiently waited. Jeremy.
Okay, first of all, Stephen's question. In terms of the transparency of salaries, this is something that was negotiated with the BMA, and the BMA agreed to it because they believed that there was a perception that GP salaries are much higher than they actually are, and they thought this would correct that perception. But I had a reason for doing it as well, which is that I want to negotiate more money for general practice, and I have to negotiate that with the Treasury. And the Treasury's view is that the GP salaries went up dramatically after the 2004 contract changes, and they are therefore institutionally very reluctant to put extra resources into general practice. And by agreeing to this transparency change, which has happened in many other parts of the public sector as well, what that allows me to do is to say this isn't just going to go into people's salaries skyrocketing. This is actually going to be going into improved patient care. What is our how can we prove that? It's because we now have transparency of salaries so the public can see that. In terms of continuity of care, giving better care for older people is, for me, the most important thing that I can possibly champion in this job. And I think that's why I believe so strongly that general practice has an incredibly important role to play. So what have we actually done? Well, in the last GP contract, we got rid of about 40% of QOF targets. We introduced the proactive care programme for the most vulnerable 2%. We brought back named GPs for the over 75s. This contract round, we have also not asked for any efficiency changes other than having named GPs for everyone, and that is something that I think will make a step towards continuity of care. But as I said in my comments earlier, I don't think we'll really be able to deliver continuity of care until we increase the capacity of general practice so that there are actually more GPs able to deliver it and give more time to their patients. And that's why the plans that I've announced, we've confirmed this week and talked about this morning, are so important. And then who did we talk about? The Prime Minister's Challenge Fund for expanding the ability of the public to get appointments in the evenings and weekends. It isn't a new project. We piloted it last year, and I talked about it at the RCGP conference last year as well, and we actually had a very, very positive response. We had far more GP surgeries wanting to take part in the programme than we had the money to give. In the end, we had to limit it to 1,200 surgeries, and that was a pilot, and it's worked. It's so far helping 1 million people, and that will increase to 7.5 million people by April. And it's voluntary, and we had a strong response. And it was on the basis of that we decided to roll it out, which is what we announced this week.
Well, thank you very much, and we do appreciate you coming to our conference. Thank you. We do appreciate taking questions, certainly I will be talking in my speech about the commitments you've made to general practice, and I believe all of us will work with anyone who recognises the value of general practice and wants to work with us to develop it. So thank you for your comments, and join me in